European Vascular Courses 2024. Yeah, let's hit the road. Let's travel together on the road to Maastricht. Special warm welcome also to the great set of speakers and panelists in here. And I do not know why you, the participants, joined today this pre-event. You might write this into the chat function that you see below because we want to interact with you. We also invite you to ask your questions in the Q&A section below. So today you can get a lot of answers from experts from all around the world. And as you may write your first comments, I would also just like to personally tell you what motivates me to when I think about the EVC. First of all, the EVC is truly devoted to education, to training, and to sharing knowledge. It's not about showing off. It's about sharing and developing skills. And I love the beautiful diversity of people from all over the globe, from different age groups, from different backgrounds, and all they're coming together with the intention to learn and to develop themselves, and in the end, to have a good patient outcome. The EVC, for me, is a great mix of state-of-the-art lectures with a broad spectrum of vital topics, including arterial, venous, and vascular access, cutting-edge cardiovascular matters, and additionally, there will be more than 300 workshops. It's very hands-on and ranging from surgical anatomy, diagnostics, medical management, decision-making, up to open and endovascular techniques. Next to that, I enjoy meeting and collaborating with the engaged team around Professor Jacobs in Maastricht. Both the medical experts and the organizers do a truly excellent job. And lastly, Maastricht is by far my favorite place in the Netherlands, and I highly recommend to come there. Today, we are happy to give you a first insight on what you can expect during the EVC. This meeting here, it's just an appetizer that will give you the taste of the EVC. It's a homeopathic portion of what you will be able to experience in Maastricht. For the full experience, there is no other way than to register yourself for the EVC and to come to Maastricht. And of course, Sigvaris Group will also be on site. We will have a combined workshop together with Philips and Kreuzler. And we are really grateful this time to have this great collaboration and a joint workshop with different industry partners. And really happy that also something like this is happening and possible at the EVC. It will be about a holistic approach to venous leg ulcers. It will be a real hands-on workshop, but it will include both diagnosis and sclerotherapy, the treatment options, as well as the diagnosis-related compression technologies that come along with this. So please don't miss out. Be part of this great event. Book your seat for this workshop at the EVC app or at the EVC website. And just remember, we just have a limited number of seats also in the workshops. So it's now the time to go in there. And with this, I pass the stage to Dr. Uman Jalai, head of the European Vascular Center Aachen-Maastricht and director of the EVC Venous team. And one of the highly engaged minds behind the EVC that make it possible. Thank you so much, Uma, for being here, for moderating this event. And I would just like to start with a question. Uma, what can we expect this year at the 27th EVC in Maastricht?
Thank you very much, Dirk, for the kind introduction. And I think you already mentioned the main points and the focus of the EVC. First of all, I thank you, Dirk and Mahmoud from the Sigvaris team for supporting this meeting, the Road to Maastricht, supported by Sigvaris, and also many thanks to my co-moderators and speakers, Rebecca Ricci, Joanna Ostorino, Tobias Hirsch, Makis Avgerinos, Nikos Lapropoulos, Suat Toganci. I didn't know, Suat, you have a German flag behind you. I thought you are from Turkey. And Ahmad Gavesh, who cannot join us, unfortunately, today. So EVC this year from 3rd to 5th of March, we have the 27th year of EVC in Maastricht. We would expect this year probably 1,800 vascular surgeons, IRs, angiologists, phlebologists, and also some colleagues from internal medicine, and many nurses. So before COVID, we had 2,200. And, with COVID, it went down. We had 1 year, 2020, One, it was with the green screen, the remote part. Then we started with 1,200. Last year we had 1,500, 600, and this year we expect people more than 1,800. It consists of 4 parts. The main 2 parts are aortic arterial, peripheral, and the venous. But we have also an access part and also a cardiac part. So the focus of EVC, Dirk, is its workshop. So just focus on the venous. We have 26 special focused venous workshops. So we have workshops of holistic approach for venous ulcer, supported by you, by Sigvaris, Kreuzler, and Philips. Just consider 3 companies. One is Philips, who is involved in imaging and intervention, and Sigvaris, who is focused on compression. And we have also many workshops regarding only imaging, like IVUS. We have duplex workshops for superficial and for deep venous system. We have stenting workshops. We have treatment of DVT workshops, which mainly is being led by Makis Avgerinos. So I think everybody will find something, regardless if he's an interventionalist or working in a private office. So I would appreciate if people can find the homepage, find the EVC 2024 app, and just consider if you are registered for the EVC, you can book and register for each workshop, regardless venous or aortic and peripheral or access, for free. You can go to 5, 6, 7, or 10 workshops. So I think that is what I can add to it.
Perfect. Yeah. Thanks, Umar. I think it's a full buffet, a full plate. Yeah. So with this, we come to the first part of this MOH talk, which is over to you.
Thank you very much. I am not going now into the detail because many people here maybe are interested more for a holistic approach of ulcer, which is the second part, or maybe the aesthetic phlebology, but we have many colleagues here, Tobias Hirsch, Rebecca, Joanna, Nikos, who are also very familiar and experts in treating also the superficial system. So, and maybe Makis and me focus on the deep venous system. I have also included 2-3 slides about the last years of EVC, and maybe it gives you an insight about the Congress. So I'm sharing now my screen with you. Please let me know if you can see my presentation. Now I am going to the presentation mode. Can you see it?
That looks good, yeah.
Perfect. So I hope this video is running now. So that was a short video just showing you that those workshops, we have presentations in the workshop, but we have also hands-on courses. We have suturing courses, cardiac courses, aortic, but also focused venous. So that is the next video. That was 2022.
Oman, do we have to book in advance for the workshops, or we book on site? And how many people
can book
attend?
in advance, and that would be nice if you book in advance. And again, if you are registered, you can book any workshops you like for free. Please use the app or go online to the homepage and register for the workshops. But you can also register inside. This is our venous room. As you can see, always full. So for the venous part, compression, aesthetic phlebology, superficial treatment, deep venous, acute, chronic, coil embolization. We have a part which goes from 8:30 to 12, a scientific session, and then the workshop, focus workshop will start. So please register. And again, for the southern countries, there is a special reduced registry fee of 200 euros. If you register, you can use all workshops for free. This is the a picture of the venous team for 2024. And you see Professor Avgerinos, Mo Barbati, who was sitting next to me, Stephen Black, Suat Duganci, Rick de Graaf, Jorinda von Lanen, Michael Lichtenberg, and Jerry O'Sullivan. All of them will be there, plus many other venous KOLs, as you see also Mrs. Rebecca Ritchie here, and also Tobias Hirsch and Joanna Ostorino are our faculty. We have 42 or 43 venous faculties KOLs, and they can address you and lead you in the workshops. I would appreciate if you go to the homepage and find the right workshops for you. This is just a picture focus of the Sunday workshop, and I focus on the holistic approach to venous ulcers, state-of-the-art diagnosis and treatment, led by Zigwaris, Reusler, and Phillips, with brilliant moderators, as you see, Berg, Hirsch, Storino, Ricci, and Mahmoud. So go inside, find it, and register for the workshop. Now I start the main topic. We are now focusing on chronic venous obstruction. These are signs and symptoms of chronic venous obstruction, or PTS. Very special are the collaterals, as you can see. For the diagnostic, we use always duplex, and also we have a focused deep duplex workshop supported by Phillips and Professor Duganci, Suat, who is here. And we have also a superficial focused duplex workshop. We combine always our duplex with MRVs. Also, we have in our workshops talks about different kind of diagnostic tools, the differences between MRV and CTV, or if we go farther, you see how to manage a venous map after performing a duplex. In this patient on the left side, you can see a total chronic venous obstruction, iliofemoral, or the patient on the right side, also a chronic venous obstruction, but with a very good inflow, which is being detected by a good duplex. So in the duplex workshop, you can learn those techniques. And here, just showing you that we use always in our deep venous procedures, independent if treating the acute DVT or chronic, we use IVUS. So we have also focused IVUS workshops. We have also a workshop which deals with 6-7 difficult IVUS or cases in whom we show how to use the IVUS. Any questions, any remarks?
Kuman, it is obvious that appropriate planning is the cornerstone of success. So I see you get a thorough duplex, you get an MRV, other people might choose to get a CTV, and you always use IVUS. I mean, yes, these three always need to be there before you do a procedure.
Absolutely. So I think also we are going to talk about these things at EVC. Yes, that is the key step for preparing a good treatment. I come to the post-op treatment, in which anticoagulation and compression is a key. But here, as you mentioned, Makis, the planning for a treatment of a DVT and the chronic venous obstruction is key. You need to have a good duplex and a venous map, plus a cross-sectional imaging. If you have it available, go for MRV, you reduce radiation exposure. But if you don't have it, also a good CTV will work. In the OR, you need IVUS. This is our non-hybrid OR, C-arm, duplex, IVUS belongs to a venous intervention. And those are pictures of our hybrid OR. Again, duplex is the main key. Just today, I came back from an intervention of a 7-month-old boy. And I did the intervention today, 3 hours with neurosurgeons. They need a ventricular shunt, but they couldn't put the shunt into the right atrium. That was performed 3 days ago. And then we made a CTV, and we saw that everything is occluded due to previous central venous catheters. So today, we just made the cut down. We approach the catheter, open it, put the wire, recanalize it, and now this very young child has now the access and his shunt working. So while, of course, many cases are easy, you go through the pathology with some wires and catheters, but also we will learn how to traverse difficult pathologies with different kind of catheters, support catheters here, Triforce, or here just showing you sometimes we need also a sharp recanalization. You see, I took a 0.18 wire from the back side, from the sharp point, and I took a needle holder and I am doing the sharp recanalization. Or here, in some cases, we need even a TIPS needle, I think this with double P. So we put a balloon from EVC, and from iliac tract, we ruptured the balloon to ensure the wire is going to the EVC. Just showing you some insights of what we are doing. Or in some cases, we need also a hybrid approach, not only with wires and catheters. In very seldom cases, we have to open the common femoral vein and perform the endophlebectomy. We will also talk about those techniques.
Kuman,
yes.
And this is great, but can you explain to me in this course, particularly the trainees and the younger people, how they're going to learn, what they're going to take away?
Yes. So first, Nikos, they can pick up first what they would like to learn, because we have aortic sessions, we have peripheral sessions, we have venous sessions, and venous we have superficial and deep. So let us say somebody is interested in deep, he can learn really from diagnostic approach, indication making, like a duplex course, like IVUS courses, like holistic approach, but also technical tips and tricks of recanalization. He can learn a DVT treatment, how to treat it, what says the evidence, what are the complications, how to deal with complications, and they can learn that intervention is not everything. An intervention without good post-op follow-up and compression and support is nearly nothing. So I think everything venous will be covered there.
Okay.
So just very fast, not very young patient, but young, suffered from a PAD 2-3 years after below the knee bypass. He had the wound healing in the lower leg. So nobody approached his venous system, his deep venous system, and nobody realized that the guy suffered from a DVT years ago. And that was on the right side, bottom, that was the picture as he came to us with the full picture of the PTS. That was his venous map showing you the occlusion. We performed the MRV, and then we went for the phlebogram in the...
May I interrupt you just because, many people here are not very familiar with the deep venous interventions. If you go back one slide, I guess we're going to discuss more about it in the workshops, but many people here would only bother about the great saphenous vein incompetence. So you see here, you show great saphenous vein incompetence, yet you don't bother about it and you go directly to the deep venous system. Other people might opt to go for the great saphenous vein first. Is this a mistake, taking care of the great saphenous vein first?
No, that is not a mistake, clearly not. This is my way to do it, and we will discuss about it in our workshops and our scientific sessions. We have one presentation in the scientific session addressing this problem. No, we discuss it also in many other congresses. We know this problem. Because I am focused on deep, I go first deep in this patient, and I know this patient had an occlusion of the entire iliac or external iliac vein and a part of the common femoral vein. But it doesn't mean that if somebody treats the GSV, it is a mistake. Even I know your cases and Nico's cases, if you treat the GSV, maybe the ulcer will also heal. So, but in this case, I started with a deep venous recanalization. That was the predilation, stenting using dedicated venous stent. We also will learn about that. And the final angiogram, just check the before and the after completion angiogram. So in this patient, that was the post-op duplex. Still, it shows the reflux on the right side bottom, but that was before the procedure and on the right side after the procedure. And I show you what patient is telling us. This is German, but now it's written in English.
Angefangen hat diese Glaubenskrankengeschichte nach einem Beinbruch. Damals bildeten sich große Einblutungen in seinem Bein. Blutgerinnsel führten sogar im Laufe der Zeit zu einer Lungenembolie. Vor der Stent-Operation hatte Peter Glaubitz massive Probleme. Sein Bein war extrem angeschwollen. Also fast doppelt so stark wie normal. Man kann nicht laufen, es tut weh und man ist körperlich beeinträchtigt. Man kann nicht mehr runter an Fuß und nichts, man kann sich da nicht mehr anziehen, waschen und so weiter. Die Bewegungsfreiheit ist immer nur auf Meter begrenzt, 20 Meter, 15 Meter. Man schafft nach Tagen jetzt vielleicht 50 Meter zu laufen, man muss sich ständig hinsetzen. Also es dauert Wochen, ehe man da wieder ein bisschen fit wird.
So you see how impaired this patient is. It is not just an occlusion and a venous hypertension which created the venous ulcer or non-healing wound below in the lower leg after the bypass. The patient is really suffering. After the procedure, opening the iliac tract and the common femoral vein, the highway is now open, the patient is doing really well. So I think with the time, I have a second case, but I will skip it because I would like Professor Avgerinos to show his case. Thank you very much.
Well, thank you, Human. That was a very, very nice case that you showed. By the way, do you want to tell us what is your protocol? Aside from anticoagulation, I mean, many of these patients may have to stay on anticoagulation lifelong. How do you handle compression? What are your instructions? Do they get the stocking immediately after the procedure? What strength and how long? Is it also lifelong compression? Is it below the knee? Is it above the knee? What are your instructions in general?
So you address now really many important points. So the post-op support and evaluation is mandatory. Anticoagulation is very, very important. We start always one day before the procedure, independent if we do the hybrid or not, with the full oral anticoagulation, if the patient is not anyway on lifelong anticoagulation. And immediately after the procedure, we put the stocking grade 2, compression stocking grade 2. It is tied to long, so upper leg for the first 2-3 months, and that it will be changed to the knee high. The grade 2 compression is very important for us and the early mobilization of the patient. So it is mandatory. We go to the ward after the procedure and we talk to the patient. Many of them, are a little bit on the pain, back pain because of the stenting. But of course, that is a main pillar of our treatment.
Swat, I think, has also a question, and then we should have Nikos Lavropoulos comment. We may be running out of time, so I may not present for now. But go ahead, Swat. Well, maybe he's not listening. Nikos, do you have any comments?
Very quickly, address the comments that made by you, Maki, and the response from Human. This patient we saw here clearly has disease that cannot, if you were to look at great saphenous vein alone, it could not explain, right, the magnitude of the signs and symptoms in the lower extremity. So this is a patient where definitely you have to treat the deep vein obstruction, right? Because the great saphenous cannot give you swelling that goes up to the knee, and it cannot give you pressure change that go up to the knee or ulcer at that location. However, subsequently, when you deal with the deep veins, right, then you can address the great saphenous vein as well.
But Nikos, that was 3 years ago. You are fully correct. But the ulcer healed and the patient is lucky, so the reflux is there. I do not know if it's less. In the flebogram, it seemed to be less, but it is just a momentum. In the duplex, it was still there, the reflux, and we didn't address it, and he's coming once a year now.
I'm not saying you should, but I'm saying, nothing to lose in a patient with such skin damage to address the reflux as well. What you did is correct. You took care of the deep veins that will explain, or basically make the patient to feel better. Now, come to the compression. People like him, even if you do all the perfect treatment, take the saphenous out, cure the obstruction, patient has remaining deep vein disease and is going to be with swelling that cannot be never healed. So this patient should be controlled by proper compression that for a lifetime, like you suggested. Okay. One other thing I want to ask you, Human, is did you see any difference in the reflux in the saphenous vein before and after the correction of the deep system?
Yeah, I told you that. Yes, in the OR, in the phlebo, if you really focus on the phlebo before the recanalization and after, yes, in the run, the reflux is less. Even the reflux in the internal iliac vein was less, clearly less. If you just from the radiological point of view, mention it and compare it. But in the duplex, to be honest, I didn't mention the time, but I still see reflux.
Okay.
And another thing is, if in many cases, we stent the GSV, we gel the GSV, all of them are patent. So the reflux stays reflux and the non-reflux doesn't change to a reflux.
Let's move to Swat. Swat, you have a comment?
Hello, everyone. Thank you for also including me. Actually, I am now at Berlin for a health tourism fair. So I was at my stand myself. So Human showed the flag behind me since I am in Germany now. And actually, I would just ask the same question with you, Nikos, for the superficial part. But I just also want to highlight about the EVC's workshops, because you know that it's the European Vascular course, its name. So the main difference from the EVC, from the many other vascular conferences, is just to bring the, mainly especially the afternoon for the young surgeons, the hands-on workshops. So anyhow, if you are not experienced, or anyhow, if you have some experience but want to improve yourself, these workshops are really dedicated, and you had a good chance to improve your skills and your information. Especially as Makis also informed for the CT and MR venography. And since there are dedicated workshops, especially how to improve your decision making and how to improve your ultrasound skills, it is, I think, very important to not to miss such workshops and to participate. Since I think it's more than 12 years I'm participating EVCs. Before I was just a student participating, but now together with my very esteemed colleagues, I am a part of the venous part, and every year still we are continue to learning a lot of things through those workshops. So I just wanted to highlight this as well.
Thank you, Suat. So just a question to Dirk and Mahmoud, because of the time, I would love Makis to show a case, even if it's very fast. Is it doable or not?
Totally doable.
Okay, so
Makis, go on.
Let me share my screen. Do you all see my screen?
Yes, we do.
Or you see the presenter view?
Yeah, you have to go to the presentation mode.
I meant to
See
present
everything.
I have two screens now and it's difficult, but I will run it through here.
Yeah,
I mean,
it's
you will
okay.
get the message. So I have this 74-year-old female. She's 74 and nobody ever told her that something may be going wrong with your deep venous system. To make the long story short, she has left-grade saphenous vein insufficiency, similar to your case, Human, but she also has chronic changes at the common femoral and external iliac vein, multiple collaterals. In my institution, we are better doing CT venograms. Look at the chronic lesions of the left iliac axis. You see how minute the left external iliac vein is. And going further down, of course, we decided to intervene. Similar thoughts like yours. We wanted to deal with the deep venous system first, accessing the femoral vein. You can see the first venogram, multiple collaterals, stenosis at the external iliac vein, and then trying to navigate our wires up. I typically use a glide wire. Look, this is very impressive. The crossover to the other side. So the left leg is draining through the right leg. So I pre-dilate with a big 12-millimeter balloon. And then you look at the waist of the balloon out at the common iliac. This is a 14-millimeter balloon. We do IVUS to exactly define the landing zones. And then we decided to deploy stents. I mean, you can start from top to bottom, or you can start from the bottom to the top. These are like little details we're going to discuss during the workshops. This is a dedicated venous stent. This is a 12 by 80, opening it up down to the common femoral vein. Yes, many people may find it weird that we deploy stents in the common femoral vein, yet this is the way it needs to be done when you have disease at the common femoral vein. More to be discussed during the workshops. And then you realize there's still disease at the common iliac vein, so we have to deploy another stent more proximally. This is a 14 by 150, overlapping with the previous stent. We do post-dilatation, again aggressively with the balloon. And now look at the nice final result. You cannot see the collaterals anymore. And this is a very good indicator that we've done the job the right way. The contrast follows the path of the least resistance. Looking also at our landing zones, proximally and distally. And we felt this is a very nice result. IVUS confirming the patency of the stent. And look how the ulcer gradually improves over time. Now, I also dealt with the peri-ulcer varicosities. I actually ended up doing the entire great saphenous vein with foam. But I think Tobias Hirsch is going to give us more details into how we should be doing foam sclerotherapy. But we had a very, very nice result. And with that, I think we can discuss if there are any questions.
Mike, very quickly something. You know, here is one of the cases. I don't know the full story of the patient, but the patient probably had a stenosis that was for a long time. That was an innocent bystander. And from what I see, the patient, you know, on X-ray has a total hip replacement and probably developed thrombosis, right? And the combination now, the major surgery plus the stenosis leading to chronic problem to ulceration. And obviously,
Exactly.
you're forced to address the problem right now.
Exactly. So many times patients do not know that they had a DVT in the past. But if you ask them, did you have a major surgery? Did you have a major accident in the past? This is when, and they say yes. This is when you suspect they may have gone through a DVT that went unnoticed over time.
So, Marcus, very fast, how are those stents you use? Can you use any stent below the ligament and put it in the common femoral vein?
So we should only be discussing about dedicated venous stents right now, okay? We should not be using arterial stents anymore. Now, we typically say that interwoven stents may be better, like the wall stent or the blue flow stent, may be better below the inguinal ligament. but actually there is no data indicating that one stent is better than the other below the inguinal ligament. I personally feel comfortable deploying any dedicated venous stent below the inguinal ligament when I have to.
Thank you very much.
I think it's time to move on to the next session so that we stay in time, and it's going to be about the overall management of venous ulcers, and I think Joanna Storino from Brazil is going to give us a nice talk. Joanna, please take it away.
Sharing my screen. Can you see it?
Yes.
Okay. Thanks for this kind introduction, Makis. We are on the road to Maastricht, and I will present a teaser on our venous leg ulcer workshop, giving some ultrasound techniques and tactics. So, a comprehensive venous insufficiency examination involves, first, clinical evaluation, anatomical study, and third, the venous valvular hemodynamics. So everything with only one purpose, that is early intervention. This picture was taken by me when I was walking through a photo gallery, and this is what I call a ulcer at first glance. And my first thought, of course, it was compression stockings. Yeah, it's kind of weird. So this is according to Professor Alan Davis, from diagnosis to treatment, we should be able to do it within 2 weeks. We can certainly do it with cancer and other diseases, so why shouldn't we be able to do this with leg ulceration? I completely agree with him, and I think it could be even faster than that. Ultrasound is the first line non-invasive test in all patients with venous leg ulcers, and it has a high level recommendation. It's very similar to ankle brachial pressure index in ischemic ulcer. So what do we need to see? Not only the source of reflux, but the source of disease, since they are not the same, they're not synonymous. So we look for the superficial venous system, the deep venous system, as you talk here today, and of course the perforators. We try to understand the hemodynamics and the anatomy of this disease. We try to find signs of incompetence or obstructions. So talking about perforators, be careful before blaming them for the venous disease. Perforators with reflux may be pathologic, but not necessarily the source of the disease. They may be the drainage. This is a book that I recommend you all to take a look. I contributed with a chapter about venous anatomy, and it brings a lot of knowledge about this issue. So vein hemodynamics is still controversial. We have limited and contradictory literature, and this is a figure which I try to simplify these types of perforators. First, we have the insufficient ones, when we find an outward flow in systole and diastole. Competent ones where we find inward flow in systole and no flow in diastole. And the third one that deserves attention because can be tricky, that are the re-entry perforators, when we notice an outward flow during systole and an inward flow during diastole. So it's considered a bidirectional one. As you all know, ultrasound for the diagnosis of infrainguinal reflux is well established. However, it has not been widely adopted as a tool for diagnosis of deep vein obstruction and incompetence, thrombotic or non-thrombotic. And we developed this worksheet trying to simplify the understanding the venous infradiaphragmatic reservoir, trying to make it simple and during your day in your work. So it's available in this QR code. So the question is, which abnormal veins should be treated and which should be treated first when multiple sites are found to be abnormal? These are the results of a multi-center cohort study where the researchers evaluated 832 patients with venous leg ulcers. And as you can see, superficial and perforator systems were involved in almost half of the sample in this study. Second, we can find the superficial incompetence. And third, the deep superficial and perforators together. So you can conclude that it's a multi-level disease. So in Maastricht, we will be together discussing, learning with each other. We are trying to understand what maneuvers elicit better reflux in different areas, the Valsalva maneuver, distal augmentation, proximal compression. So it's going to be a hands-on and very comprehensive and learning experience. That's because training is of fundamental importance. It's strongly dependent on the skill and experience. I recommend you to take a look in this article who should do diagnostic venous scanning. And of course, it depends of the type of scan required. It can be really easy when we are investigating DVT, for example, but it can be very difficult in patients with post-thrombotic syndrome. So it's tricky sometimes. In conclusion, patients presenting with venous leg ulcers can be quite complex, and I really want to make it simple. Sometimes you just need to know where to look for it and how to look for it. And in search for knowledge, nothing better than a master's advice. So I asked Professor Haag, how can I better understand and study venous hemodynamics to improve the treatments I offer to patients? And his wise answer was, you should perform venous scanning of them whenever possible. So let's do it together in Maastricht, and thanks for your attention.
Thank you very much, Joanna. It was a great and very well-structured presentation. I'm really looking forward to what's coming next in Maastricht. So of course, I mean, there we can really go much more into detail, and also enjoyed the discussion before already quite a lot. So it's just a very small puzzle piece that we can show today. So in order to see the whole puzzle, you have all to come to Maastricht, of course. Are there any questions, comments?
The only comment I want to make is, ulcer is a complicated issue, and it's, in my opinion, completely a multifactorial disease. It is not just a reflux or obstruction. If you look at patients carefully, a lot of them have, disorders of their feet, such as flat feet or concave feet, They have, obesity, right? They may have previous infections, right? The lack of physical activity. So it's many things. More importantly, when we look at the ultrasound, what we find on the ulcer is interesting because it depends on your pattern of referral. If a cosmetic practice, and you see some ulcers with a little bit of, ulcer in the medial malleolus, it's very likely to be an ulcer because of superficial disease. But if you go to university hospitals or major places, then you're going to see the involvement of deep system is much higher, right? So it is not so easy to go in a book or read a paper like the one by Peter Lawrence and say, oh, this is like more superficial disease. Indeed. But the importance of deep venous system, I think in the publications has been often undermined, but it's nobody's fault. It's really referral pattern.
Absolutely, could not agree more. I think it's really an interdisciplinary thing. So therefore, I'm looking forward to have this interdisciplinary approach. During the EVC, during the workshop on the ulcers. One part of that, of course, will also be the sclerotherapy, which will be a big part. And we have Tobias Hirsch with us, who will also give you some insights of what will happen in Maastricht, and also some insights what role sclerotherapy plays in the approach of leg ulcers.
Thank you, Dirk, for introducing my person, and thank you, Human, for inviting me to Maastricht once again. It's always a pleasure to be there, and an honor as well. And I love to join this workshop, this masterclass about a holistic approach to venous leg ulcer treatment. I think what Nikos told us is one of the most important issues. It's not only a superficial reflux that we have to treat, but this is one issue we can provide to the treatment. Patient education probably is the most important issue, and nutrition and all these issues have to be kept in mind. But what we can do is what we see when the patient presents in our practice. And I think after we have identified the source of the reflux when superficial vein disease is the cause of ulcer, we can then continue treating. Compression is one of the most important issues, but sclerotherapy can also be a very valuable part of the treatment. And now I want to share my screen. Is it working? Can you see my screen? Is it okay? Well, physicians have been using sclerotherapy to treat varicose veins for centuries. Modern sclerotherapy enables us to treat side branches, truncal veins, and also spider veins like this, and venous leg ulcers as well. The procedure is very gentle and has few side effects. It's backed by a lot of evidence which is contained in the international guidelines, as you can see in the baseline. Only 1 in 10,000 patients is suffering from one of these side branches. This is more gentle than any other varicose vein treatment options, and it's cost effective. You only need a needle and 2 syringes and the sclerosant, and this only a couple of cents, an issue of cents. We can combine sclerotherapy with any other treatment modality. There is a channel in the RFA catheter that enables us to administer the foam, and there are special laser devices that are only compatible for that, and you can feel free to use sclerotherapy also in when you prefer open surgery. So we can conclude sclerotherapy is the multifunctional tool that fits into every toolbox. And how does sclerotherapy fit to ulcer treatment? We can treat truncal veins, we can treat the perforators that also play a very important role when it comes to ulcer healing, and then we can treat the feeder veins in the ulcer tissue bed. According to the European guidelines, ultrasound guided foam sclerotherapy is suitable for treating truncal veins. I have a delay now. Could you hear this delay as well?
Yes, and now it stopped.
Yes, we don't know why, but it was horrible. Psycho. So, according to the European guidelines, sclerotherapy is suitable for truncal veins with a diameter less than 6 millimeters, and according to the choosing wisely recommendations of the French Society, it's the first-line treatment option for diameters less than 4 millimeters. This is Alan Davies at the Charing Cross 2018, and here he is presenting the EVRA trial, which was a game changer, and which is the first study to provide level 1 evidence for using early endovenous ablation to treat ulcers. The conclusion of this study was that in the early intervention group, ulcers healed faster, and also free time was longer. When talking about endovenous procedures, we mean radiofrequency ablation, we talk about glue and laser. One special thing with this EVRA trial is that the majority of the patients were treated only with foam sclerotherapy or had sclerotherapy as an add-on treatment. When one advantage of sclerotherapy is that we can treat both truncal veins and perforators, but also the feeder veins of the ulcer. And this is what we do in our center. It's a very easy two-step procedure. First, we treat the perforator using a direct puncture or a sheath. After we have closed off the truncal vein, if the truncal vein was the source. And it's important to use low volumes of the sclerosant when it comes to perforator treatment, but a high dosage. So we use only 1 or 2 millimeters polydocanol, but 2 to 3%. And once the perforator has been occluded, we can start with the second step, the treatment of the feeder veins and the periulcerous vein network. It's easy to visualize the refluxing feeder vein just by compressing the tissue around the wound, and you can see the color changing. And under ultrasound guidance, a needle is inserted and the microfoam is applied. And for this we need higher volumes, because this network is not only the thin veins we can see using a vein light. In the depths of the tissue we can see that it's a big network, and we under ultrasound control you can apply the foam, but we use a low dosage, and have to make a note, polydocanol foam 0.5% is off-label use, but this is how we do in our practice. This British work group published the results of 200 patients and 37 with ulcer who underwent this kind of treatment, and 1 year after foam treatment, more than 90% of the treated ulcers had healed, and the 24-week follow-up date makes it possible to compare the results to the results of the ESCAR trial, and their healing rates after ultrasound-guided foam sclerotherapy were even higher than in the surgical arm of ESCAR. Similar results in this study, 82% of chronic wounds healed within 3 months. I have prepared 2 cases from my practice. This is a 76-year-old female who presented in my practice with this ulcer. I saw her the first time in 2014, and we did a small saphenous vein treatment using Clarivane. She underwent a stripping before, already in 2009, but this is from 2021, I think. And the source of this also was the Cocket perforator. And we did exactly what I have presented a couple of minutes before. And this is the result after 2 sessions of ultrasound-guided foam sclerotherapy. And here we have another case. This is a case with a GSV disease, reflux up to the down to the ankle. But as you can see, 3 months after radiofrequency ablation, we don't have a complete healing of the ulcer. We see a clear tendency of healing, but this is not healed. And so we continued with the same protocol. And this is after 3 sessions of foam sclerotherapy of the ulcer bed and feeder veins of this ulcer. It's clear that we also used wound dressings and consequent compression therapy for those patients, but as an add-on, we usually also perform sclerotherapy. So let me come to the take-home message, and probably you are already at home, so take it as a message. Sclerotherapy can be a standalone procedure or an add-on in ulcer treatment. Sclerotherapy does not damage the integrity of the skin. This is also very important. Cases of recurrence. We know that other techniques can be superior to sclerotherapy, but sclerotherapy is gentle and very cost-effective, and you can do repeat treatment, and cases of recurrence can be easily dealt with during the follow-up wound treatment sessions. The patients come to your practice because the wound has to be treated, and last but not least is the most cost-effective reflux treatment, and also a cost-effective treatment option for ulcers. When you keep in mind, you have to keep in mind that wound dressings are very, very expensive, and these are the topics we will teach you when you come to Maastricht and join our workshop on the holistic approach to venous leg ulcer treatment. Thank you very much.
Thank you very much, Tobias. Great presentation, and I also like the Swiss knife, of course, and you have been also sharp as a knife as usual. So I think it's good that we see there's many ways and let's say different parts that need to put together in order to treat an ulcer in the right way. So we also have a question now in the Q&A. It's how about just obliteration creates a venous vein and injunction of perforated GSV ablation more longer to make sure they close. Yeah.
The point is that perforators have always a high rate of recurrence. So we know that the results after sclerotherapy are inferior compared to laser or radiofrequency or SEPs, but this is not an issue in perforators the same way like it is when we talk about truncal veins, because we have a reflux, we have a recurrence rate of around about 50%. And if you use foam or if you use a laser or whatever, and so you have to you have to make clear that repeat sessions are necessary. But the point is, you see those patients again and again because they have ulcers. And on the other hand, we have a recommendation only to treat perforators if they are connected to skin changes or to ulcers. You should not treat perforators only when you treat a C2 venous disease.
Thank you very much, Tobias, for answering these questions. Are there any other comments or questions from the panelist side?
I just would ask Tobias about the complication of direct puncturing of the perforator and sclerosing it. Even you use 2 milliliter of a higher percentage.
Yes. You think of
DVT.
Deep venous DVT.
Yes.
Yes.
Yes. And I am really asking you because I have not much experience. So
Yes.
you are doing it every day.
Yes. Yes. It's always a question. The recommendation is not to treat perforators with a direct puncture, but the foam will always run into the deep venous system. This is always the case. You cannot do anything about against that fact. And so we ask the patients to flex the ankle and to move the legs a little bit, not the leg but the foot, as a kind of DVT prophylaxis, but I have never seen a DVT after that type of treatment in my practice. You have to inform your patients about the risk of DVT, but you have to do that always when it comes to sclerotherapy or vein treatment. But I think there is no higher risk to induce DVT. But you should use only small volumes. I think this is important. If you put in 10 milliliters, you have 10 milliliters in the deep venous system. And the point is not that the patients will have DVT after that procedure. The point is that higher volumes will affect other regions. So they will have visual disturbances and all these things that can happen when you use bigger volumes of foam.
Thank you.
All right, so from deep to superficial, we're coming to what's happening around the leg, and we change from Germany. So warm welcome also to Rebecca, and we're looking forward to your presentation. So the stage is yours.
Thank you. Let me know if you see my screen.
Yes, we did. Yeah, we've seen it a few minutes ago. Yeah, when you start sharing.
Okay. Well, I guess my presentation is a little bit bored because how can I say it? About compression application, I have no disclosures for this. Do you see my screen?
And now you don't see it. We've seen it a few minutes ago when you were sharing.
Okay, I stopped sharing, but now let me see. Do you see now?
Yes.
Okay. Thanks for the invitation. I have no disclosures, but I guess this is a little bit, boring about compression and all the recommendations that we have, because this is an important article by Dr. Parch that he has just left the last year. And he was like the master of compression. So I guess this is important to know the grades of recommendations, because sometimes the patient doesn't want to use any compression stockings. So we have to know that there is a very important part of the treatment of the patient with ulcers. So we have different recommendations. For example, we have recommendations for chronic venous disorders only in healthy individuals. We have recommendations when we have skin changes caused by chronic venous diseases. We have recommendations for preventions of venous leg ulcers recurrence. And we have recommendations to improvement the healing, that it's the important thing of this talk. So we have that they recommend to use the of ulcers kits that we know nowadays. This is the name of, to improve the healing of the venous leg ulcers. And they recommend to reduce the pain too. If we remember, the patient with a venous leg ulcer has a lot of pain, is a lot of discomfort, and they have a lot of edema. Sometimes they have a swelling, and it's sometimes they're infected. So part of the treatment, of the complete treatment of the venous leg ulcer, is, of course, the compression stocking. So the 8th recommendation is the prevention of the progression of venous of chronic venous disease. This is well recommended. However, the evidence of using in treating established ulcers is less clear. Since 2008 consensus document for specially designed ulcers kits have no development. They consist of a 2-layer stacking system for uniform graduated compression and ease of application. This is very important. There's only 2 layers. There are some of them that have 4 layers. So we have to choose which one is the best for each patient. So for a talk, it's sometimes difficult to show how to apply this kind of compression. So the thing is that you have to know that it's a beneficial effect for a venous leg ulcer healings. And it has been developed in several trials. But we have to know when we have to apply it and when we cannot apply it. So these are some contraindications about the compression stocking, the medical compression stocking, with patients with severe congestive cardiac failure, as the risk that they may develop systemic fluid overload. From moderate edemas without can be achieved using light, no moderate, no high compression. It's light compression. And we can use light compression and the post-reconstructive edema after a successful bypass surgery. Sometimes this kind of contraindications, we have to see each patient because each patient is different. So we have to know when we can put a medical compression stocking light, medium, or high. So in patients with clinical limb ischemia, we cannot put it. In advanced peripheral neuropathy, we cannot put. In patients who are older and they have like paper skin and they have another kind of troubles, we cannot put. And in patients with dermatitis and allergic reactions to the fabric, of course, we cannot put. That's why they put, first of all, we can put something with cotton, that is a sock with cotton, so we can reduce these allergic reactions. And for unusual leg sizes, shapes, or deformities, or stand-on of the shell stacking is unlikely to fit the patient. In these cases, the medical compression stocking should be customized by individuals. Like everybody knows, we are different. So we are going to talk a little bit about the compression fit standard calf foot. I guess this is a very good system for that applies. We have foot and we have calf, and this is calf and foot. So we can choose what we need, where we need the compressions. And I'm going to show you a YouTube video that it's very quick. But if you need to know how to apply it, it's the best going to with us to the EVC, and I can show you how to do it and how you can choose the best compression stacking for your patient. Like I said, it's kind of difficult in a few minutes to show you, so that's why I have to show you by person is this is just a video that we have from YouTube that it's very easy. It's 1 minute only, but you can have a good idea of how you can show your patient how to wear this compression stocking.
The Compraflex Complete is a versatile wrap that is indicated for wound care, including venous stasis ulcers, chronic venous insufficiency, stage 1 or 2 lymphedema, and post-surgical edema. It is made from a medical-grade laminated foam material, which is designed for better moisture wicking and air transfer. The garment can be set from 20 to 50 millimeters mercury compression. The garment includes medical-grade hook and loop for a long-lasting secure fit. The garment also features a curved spine for a better fit, along with a stretch panel for easy donning. The complete liners include a padded foot and ankle area with 10 to 15 mmHg compression that is gradient from the ankle to the top of the liner. The garment includes one Compraflex wrap, a pair of complete liners, and a set of AccuTap devices. Make sure your skin is clean and dry. Begin by donning one of the supplied liners. It may be easier for you to fold the liner in half as shown, or simply pull the liner on. With the stretch panel facing forward, slide your leg into the wrap. Pull the garment up the calf until it is roughly 5 centimeters or 2 fingers width from your knee crease. Close the straps without applying any tension, making sure that they are flat without gaps. Place one AccuTab device per strap as shown here, making sure that the size and AccuTab print are facing the strap. Apply each strap to the desired compression level.
Okay, let me share again. Let me see if I can share. So this is an invitation. So you can know how to do it. So for the video, you can see that it's very easy to use it, and we have to learn how to put it and how to take it out, because it has a way to take it out. And of course, after all, we have not only CompraFit calf and foot, we have CompraFlex, and we have only from the calf, and we have the boot. So if you want to learn everything of this, you have to go with us to the EVC and take how can I say it? I forget the word in English. Forgot it.
Go in Spanish.
No.
Nicholas can translate.
Oh,
No te
yes,
preocupes,
Nicholas,
Rebecca,
please
por
help
favor,
me. ¿Cómo puedo decir que vayan al curso, a tomar el curso para que aprendan a ponerlas?
To go to the workshop to learn all these things.
To
Yeah.
the workshop, yeah.
Absolutely,
I forgot the name of the
absolutely, they're
workshop,
great.
Yeah, thank you very much. Yeah, thank you. And besides that, this garment strap system gives it the high range of adjustability, creating an accurate custom fit. This is very important. This is almost one of the unique that we have this adjustable, and it's very easy for the patients when they know how to put it. So my conclusion is that the very important, the venous leg ulcers are one of the most important complications of the chronic venous disease, and it has a very great impact of the quality of life of the patients. So we have to know how to apply appropriately. So you can use it every time you want it. And there have some techniques to use it. So if you want to learn it, come to the workshop. Thank you.
Perfect. Yeah, thank you so much, Rebecca.
Thank you, Rebecca.
I totally agree. I think it's a very interesting